should be celebrated with loved ones. But I'm here alone. I can go back to my mom's home. Why do you go to my house with me? Erika, what are you doing here? I want to see you.
Dr. Solomon, good evening, sir. Hello.
Hello, Dr. Sir. Good evening.
How are you doing, sir?
I'm fine.
Okay, the moderator is in the education committee group complaining about difficulty in entering.
He's not entering. Are
Yes.
you sure he registered or he paid for his?
Has he joined?
He has not. I
Good
just sent
evening.
him the meeting ID and passcode for him to use to join. We are still not entered. Maybe we should just address the participant that we should just give a few minutes before we start.
Okay, no problem, because I don't know whether he's owing SIPAN or something of that nature. Our financial officer is strict, which is a good one.
Dr. Bello, good evening. It's from Choma. It's from Choma Fonko. I'm not the moderator for today, and I was the one complaining that I couldn't enter, but I have finally entered.
No, Dr. Obinatu, the moderator too could not enter.
Okay.
The moderator too had the same issue, yes.
Thank you.
Okay, you're welcome. Good evening, all. We'll start in another 3-4 minutes by His grace. Sorry, please, just let's hold on a bit. Latest by 9:15, please, we'll be starting. Dr. Isa? Dr.
Yes,
Isa, please. Okay, well, good evening. Please, we'll wait for Dr. Obina. Hope that he will be able to join us by then. If not, just stand in and let's start. Thank you.
All right. Okay.
Good evening, ma'am. Our presenter for tonight, ma'am. Pharmacist, Mrs. Lawal. Yes, ma'am. You are welcome, ma'am. Sorry, ma'am, for the beat. We will start. Yes, ma'am.
Thank God.
Yeah, we are looking forward to tonight. Fine, ma'am. Yes, ma'am. Thank you for always, ma'am.
Thank God. Let's see.
The moderator has joined us, so why don't we start?
Okay. Dr. Obina, welcome. Juanito. You're a co-host, so you can always unmute yourself.
Yes, he has joined. Good.
Hello, moderator. Dr. Binawandu, can you hear me? You need to unmute your device so that I can hear you.
Hello, can you hear me?
Yes, sir, we can hear you.
Okay, that's fine.
Dr. Obina.
Hey, yes, I can hear you. Yeah?
Okay, let's start, sir. Let's start. We're waiting for you.
Okay, all right.
Let's start. Yes, sir.
Okay, I think we have to start with opening prayer. May I ask for a volunteer for an opening prayer, or should I nominate somebody? Okay.
Dr. Issa, please give the opening prayer.
Okay, welcome.
Okay, let us pray. In God's mighty name, we start this meeting in his name and beg that he should guide us through so that at the end of this presentation, we're able to take one or two things from our presenter. Give our presenter the ability, the strength, and the wisdom to pass the knowledge that she has prepared for us tonight. We ask you for your grace throughout the clinical meeting. In Allah's mighty name, I pray.
Amen.
Amen.
I want to thank everyone that's here present. Let me start by saying we're a little bit late and I'm sure we're going to meet up. I believe that today's topic is what everybody wants to know and hear. Everyone wants to know how to improve our finances. Everyone know how to leverage our resources, our capital, our clinical judgment, and how to make the most of the much we have known. Some people say that pharmacy is one profession that knows too much and gets not much from the much that they know. But I believe that with what we're going to hear today, we learn how to maximize the much we have that we think is little and convert it into cash. So on this note, I do want to mention that the normal protocol for the meeting code, time for question and answer, you raise up your hand. If you're not sure to unmute, you don't need to unmute. So I think on this note, I want to invite the presenter to unmute and start the presentation right away. We're already run out of time.
Good evening, distinguished colleagues. Thank God for another opportunity to rub minds, because we are here to rub minds this evening, and I'll be facilitating this session. So I will share my slides. I want to appreciate the organizers for the opportunity. And like I said, it's sharing of experience. So I'm trying to, okay. It's sharing of experience. So please just note areas that you want us to discuss further as we go. And just seeing that sent together. So my topic is maximizing the clinical pharmacist knowledge and skills towards income generation in pharmacies. You will agree with me that if we sit down here from this time to tomorrow morning on this topic, we cannot finish it because it's a very big topic. But like I said, I will just share a few experiences with us, then we'll discuss. And we all know that as clinical pharmacists, there's a lot on the inside of us. We have a lot of potentials, and this work is enormous. There's so much for us to do. So we will be able to position ourselves in one or two things as we go along. So my outline is this. There'll be a brief introduction, then we take some definitions of the key terms. And then we'll look at examples of clinical pharmacy services, opportunities, challenges. Please let me know if anything is happening and probably you're not seeing my slide or you're not hearing me well. So as we all know too, our roles as pharmacists keep expanding from the traditional drug dispensing, whereby we will get more focus on the drugs, to patient-centered care. That's what is in vogue now. Coupled with this are expectations from the patients and public, and everything now impose the quest for more clinical knowledge and skills on the pharmacists, especially pharmacists in the hospitals, community, or those engaged in direct patient care. And this has birthed the crop of pharmacists known as clinical pharmacists. However, there are a few problems out there. And for this presentation, I was able to identify about 3 statements of the problem that we'll be looking at. Now, one is the notion that pharmacists should be remunerated only for products is still very much in vogue. Many people don't think that pharmacists should be remunerated for services. But we all know, like it is said in the Holy Book, that a workman is worthy of his wages. The clinical pharmacist, like any other workman, is worthy of his wages. It deserves to be remunerated for the services it provides. Another problem is that the burden of healthcare costs on the patient is high, considering that most patients pay out of pocket, and that is also a challenge or an issue. And then some clinical pharmacists are yet to implement service delivery in their practice setting. So we'll look at all of this as we go along. Now, permit me to refer us to this quote. It says, the best feeling in the world is seeing the benefits and rewards of hard work. When we work very hard and we get the reward, naturally we feel very good. So let's look at definitions of the key terms. Income generation. I tried to find the right definitions there, or the definition that will capture our topic. And I had to split it into 2. Income means money received, especially on regular basis for work or through investment. That's according to Oxford's English Dictionary. Then generate means produce or create. So income generation means to produce or create money on a regular basis if we combine these together. Then knowledge, as we all know, is information, understanding, and the skills that we gain through education or experience. That's how Oxford Learner's Dictionary puts it. And it says this experience could be in practical, medical, or scientific knowledge. Then we'll look at skills. Skills are abilities to do activities or jobs well, especially because we have practiced it. So a skill is basically an ability to do an activity or a job very well, especially because you have practiced it. That's the Cambridge Dictionary. So now, who is a clinical pharmacist? That's a question that I tried to find answer to. And the best I could come up with is that a clinical pharmacist is a medical professional whose primary concern is to optimize patient care and help patients find medication therapy that promotes health and prevents diseases. A clinical pharmacist works directly with physicians, other healthcare professionals, patients, and caregivers to ensure that the patient gets the most effective clinical outcome. So as clinical pharmacists, our focus is the patient. We want to be sure that our patient gets the optimal clinical outcome from his medication. We want to also help our patients to prevent diseases. So we have a lot of roles to play in the life of the patient. I listed some skills here. They are not exhaustive. You may add to them. These are just my own thoughts based on what I do too. So a clinical pharmacist skills, a clinical pharmacist should be very good in communication because communication can make or mar. A clinical pharmacist should have empathy. He has to have friendship formation skills. He must be able to make friends because he needs friends all the way. Friendship with other healthcare professionals, friendship with the patients. If you are going to get at the patients, if you want to get the necessary information, if you want to help the patient, you have to be that patient's friend. Then the clinical pharmacist skills include critical thinking. We need to be able to solve problems in the treatment of an eye. Listening, very important. In clerking our patients, we must have very good listening skills. And we agree with me that we do. We do a lot of listening. Some patients will tell you that they see some healthcare professionals who don't listen very well to them. They just summarize it. We listen to them, and that is why they run after us. So the clinical pharmacy skills includes listening, precision. We must pay attention to details because we want to optimize outcome. So every detail matters to us. Conflict resolution, compassion, and I keep looking for every opportunity to stress that compassion is what makes us go the extra mile to help our patients. And that is what the service is all about. It is when the patient is at the center of the care. It is when we put ourselves in the patient's shoes. Then leadership, stress management, because a lot of stress is involved in the work. And then stamina, stroke, endurance. So these are the skills that I was able to do. Like I said, it's a discussion at the end of the day when I'm done with discuss. So I expect that this list would have been elongated. Please, if you have more, just note them somewhere. We'll add them later. Now I looked at the key roles of the clinical pharmacist and I put them into 4. Number 1, we prioritize the patient. The priority is the patient. Our focus is the patient. Then the clinical pharmacist prevents the patient from getting harmed by medicines. We know that medicines, when used irrationally, harm the patient. So the clinical pharmacist comes up strongly there to ensure that rational use of medicine is promoted, is instilled. Then the clinical pharmacist's key role is also to promote the health of the patient. So no matter how healthy the patient is, we want the patient to get healthier, then protect the patient from diseases. So we will look at all of these in practical terms as we go along. How does the clinical pharmacist care for patients? The clinical pharmacist provides a consistent process of patient care that ensures the rational use of medicines. And this comes under pharmaceutical care services, which we all do, comprehensive medication therapy management, chronic disease clinic, vaccination services, travel medicine services, home care services, medication use review services. These are services that the clinical pharmacists render to provide consistent process of patient care. Well, this is purely what I put together, this slide. The clinical pharmacist's indispensable companions from my over 30 years of experience on the field. I consider that these are companions that the clinical pharmacist must have to render services to the patients. Caring hearts. It's all about care. Pharmacy, clinical pharmacy is all about care. Integrity is very important. We must be trusted. Our yes has to be yes and our no has to be no. So we must work with integrity. It must be that the patient is more important than the money that the patient is bringing in. Then creativity, we have to be able to use our creativity to get things done in the best interest of the patient as well. Knowledge is indispensable. We keep learning, acquiring knowledge so that we can do better. And we all know that wisdom is application of knowledge. So wisdom too we cannot do without. Resilience, we just have to keep doing what we know is the right thing to do, irrespective of what is happening around us. And that's why I list it as one of the indispensable companions. We will not give up because we know that this is the right thing to do. On the short run, it may look like it's difficult. It may look like there's no income, but if we persevere, things will take shape. Then gutsiness or courage. We have to be able to take risks over certain issues. There are many interventions that, by God's grace, we have done, and they are costly in terms of putting so much money into it. But when we know that this is beneficial to our patient and is the best thing for the patient, then we go all out, and more often than not, it ends well. But you see, we have to take the initiative. We have to have the guts sometimes. For example, we know that there are some drugs that just must be on prescription, and the patient wants to take it without prescription. You say no, because this is my knowledge. I know that this drug might harm you if you are using it the wrong way. So I'm not going to give it to you. That's guts, really, because sometimes they walk out on you and get it to somewhere else. Because we know that in Nigeria, drugs are easily accessible. So another thing that is indispensable is discernment, because it's not just about the patient has brought a prescription. Even when the patient has brought a prescription, we need to be able to discern. I recall some years ago, a patient living with sickle cell brought a prescription from a teaching hospital, and this patient, outpatient, was on pentazocine, was on an NSAID, was on Panadol, so many combinations of pain relievers. And I looked at this prescription. It really looked, it was really from a teaching hospital, but it looked, I had to think through it. And if you see down the line there, I put prayers because that is the truth. That's the way I work. Sometimes in my heart, I'm just praying and asking God, help me. So I could not say I would not dispense this prescription because it was a prescription. But at the same time, I knew something was wrong. So I had to find a way to reach the hospital. And they said the name on the purported prescriber did not even exist in that unit. So it was a fake prescription at the end of the day. So what I'm saying is that for us as clinical pharmacists, there are some things that we just must have as our companions. Every day we carry with us. And like I said, just like this, just what I made up. So, needed tools. For us to effectively carry out our services, it's nice if we have a counseling room or corner. We need documentation materials like computers, software, referral booklets. Thank God the Association of Community Pharmacists has referral booklets, and I recommend that for our use because it promotes us as a group and it makes it more reputable. Then we must come up with standard operating procedures, guidelines. We should have monitoring devices. However, there are still some services that we can render even when we don't have an office. So when you want to, as a clinical pharmacist, before you render your services, you need to ask yourself certain questions. What service do I want to render? Because there are myriad of services out there that our patients can benefit from. You know, recently I went online to search if pharmacists can be involved in Medscape article that showed that so many services that we can render. Then why do I want to benefit my patient? Is it something that my patient needs? That should be a driving force for us. If my patient needs it, then it's a service that I am protected by law to do it. Then I should want to carry out that service. Then what do I require for the service? Who are my targets? Who are the people that will benefit from this service? How do I reach them? This service I want to do, is it sustainable? How do I sustain the service? Do I need mentoring? These are questions that we need to ask ourselves. So I will give an example here on setting up a chronic disease clinic. Like I said, there are so many services, but imagine that it's a chronic disease clinic that you want to set up as a clinical pharmacist. What do? You need to identify and plan the chronic disease to address. So you need to decide what chronic disease do you wish to address first. It could be hypertension. You could want to identify, it could be diabetes, it could be asthma. Then determine the recruitment criteria, because you will need to recruit people. You can't go it alone. You will need to recruit people if it's a clinic that you are setting up within your pharmacy. I'm not talking of a hospital, just a section of your pharmacy there. Then you have to come up with your vision, mission statements. You have to communicate with and train all the staff that are concerned. You need to select your needed materials, select other healthcare professionals that you want to work with, and then start with 1 or 2 clients so that you can build up gradually. Now let's look at setting up a diabetes clinic within the pharmacy, for instance. You need to train your old staff or hire new staff with diabetes management experience. It's either you are training your old staff on diabetes management or you hire a new one that has diabetes management experience. Or you get extra staff for the clinic only a few days of the week. For example, if you're not going to do it on a daily basis. Maybe you just want to do that on a Monday or Tuesday, or maybe 3 days in a week, then you can get an extra staff, somebody that will come in as part-time for those days. Then you need to define your mission, and then you must have your training or communication. You communicate with the staff about the new clinic. You do diabetes management training for all staff, because all staff will have one role or the other to play, even though you have some people that are directly in charge. So of course, you must familiarize yourself with diabetes guideline, because you will need to refer to it and possibly get a copy within this corner where you are going to have the clinic. Then let's say this is an example. Vision is optimal diabetes care. And our mission for this diabetes clinic is to help diabetes patients to have full control of their diabetes through provision of evidence-based information, education, care, and optimization of their therapy, while working with pre-diabetes patients to prevent or delay maximally progression to diabetes. Then this is an example of a standard. You will have many standard operating procedures to address different stages, but this one is particularly the standard operating procedure for carrying out blood glucose check. And the procedures are clearly written there, what to do first, second, like that, till the end of the process, so that there's uniformity of process. And then there has to be a guide for diagnosis, because you might have to do different kinds of tests depending on what you want within your pharmacy. You can do HbA1c, you can look at fasting plasma glucose, you can do random plasma glucose. So you need to get materials that you need. And for diabetes, a glucometer is inevitable, meaning strips, piercing devices. What we do is to make sure that we use the piercing devices that are retractable, just to ensure that we minimize the risk of infection or accidental puncturing. So what we use are this, what we call Safety Pro. And then we also do fit examination. So you might want to do fit examination for your diabetes patients. And these are some of the devices that you will need. Then you need monitoring the materials. For example, you want to assess your diabetes patients for hypoglycemia, which you know is very important. So there are questionnaires that the patient can fill that will help you to know if at certain times of the day or periods, your patient is likely to go into hypo or experiences hypo, so that you can intervene. Then we have this monitoring material on my left, the AccuCheck 360 View 3 profile tool. It's also a very interesting tool. We use that more when the patient is not well controlled and want to know what really the situation is. Sometimes it is that they engage in certain behaviors during the day that affect the sugar. It may not necessarily be the drugs. With this, you can find out, because using this material, the patient monitors or measures his or blood sugar 7 times each day, consecutively for 3 days at targeted times. And then you plot a graph. At the end of the day, you're able to know at what point there is a dip or a rise in blood sugar. Then this is also monitoring materials for the fit to look out for neuropathy or nephropathy. You will also need education materials. This particularly is quite useful. It takes your patient through the diabetes journey, and it helps you to position the patient as the driver's seat of his condition, so that it takes control So you empower the patient to be able to manage his or her diabetes. These are also diabetes education materials, these two. And then diabetes ancillary products, you make them available. We are looking at just one major service, that's a diabetes clinic within the pharmacy. You need to identify who your collaborators are, other healthcare professionals that you will need, because it's not a one-man show. It's multidisciplinary. So you will need GPs, you will need laboratory scientists, etc. So you need to identify them, and that is why those skills that we talked about earlier are very key, because we need to build relationships, we need to have teams. In vitro drugs, for instance, we have teams that we work with for different conditions. When we have the patient that needs gastroenterologist, we know who we are going to. So we have a list, and we make sure that their contacts are easily accessible to those who are engaged to do this. Then you might need to set up or identify with diabetes support groups. We have what we call Victory Diabetes Group for our patients. And then you need to reach the caregivers as well. In all of these situations, as you meet needs here, incomes will naturally be generated. Now, to start up, you start with one or two clients and see how the clinic works. Look out for problems that may come up or processes that make the clinic run better. Continue adding patients gradually until the person you are put in charge is familiar with all the processes. Then naturally, you will have to do patient physical assessment and medication use. So you start by clocking your patients, you do medication use review, check adherence and side effects, if any, that the patient may be experiencing. And you more often than not find out that there's a lot to do with adherence. And when you get your patients to adhere to therapy, your patient benefits from it, your patient gets better, and naturally income also comes in. You check for drug therapy problems if there are potential and real. You check drug administration techniques. For example, if the patient is on injection, make sure that your patient injects correctly. You check if your patient is on any new medications, and especially sometimes they are on herbals, they are on complementary medicines. So you need to make sure that you check on that and be sure that there are no drug interactions. Recently, I read an article about a patient that took ibuprofen and ginkgo biloba and had serious bleeding issues. Then you need to refer as needed and follow up. Follow up is very critical here. The more you follow up on your patient, the more you are able to help your patient to optimize the interventions that are in place. Many times, if you leave the patient, then you are not likely to get optimal results. Patient education and follow-up. You need to discuss with the patient key things to know about his diabetes and medication, and then you bring in life experiences. It's good for them to know that many people live long with their diabetes because they do what is right to do. Then you need to help them to set realistic health outcome targets. Give the patients information leaflets as take home, things that you want them to do, write it for them to take home. Ensure that your patient has good experience with you, very important. Take feedback. Give appointments, follow up. Now let's look at this clinic that we have just described now, which area registration fees? Usually, so you can fix a fee there, care tests to help the patient. You want to help him to know if he's getting control. You want to help him to, like today now, a patient just called to say, oh, my sugar just rose suddenly. I don't know what happened. I think it started from yesterday. The BP, the glucometer, she said she measured her sugar and it just rose suddenly like that. So we said, okay, come over. Come with your glucometer. And then the patient came with her glucometer and we checked her sugar using our own glucometer. We checked using our own glucometer, the difference was a lot. With us, we got normal value, hers was high, and then to confirm, we did HbA1c, and the HbA1c was good. So we concluded that our glucometer had an issue. Then home services, you can reach them at home, and that will also attract a fee because you are meeting needs. When needs are met, then income can come. Of course, they are on chronic management, so they keep filling their prescriptions from you. And you also have to engage them in preventive care services. For your diabetes, this case that we are looking at now, the patient will need to be protected from hepatitis because that patient is constantly picking the finger. So it's important that the patient has hepatitis vaccine, pneumococcal, flu, Tdap, as the case may be. And then there will be ancillary products too for this patient, so they don't live boring lives. You may give them products like dates to use instead of sugar. Apart from that, they need to have glucose with them in case they have sudden bouts of hypoglycemia and they need to put sugar in there. Then lifestyle modification services, exercise. We know that with diabetes and with almost all of these chronic conditions, exercise is key. So when the patient has to exercise, the patient might need some exercise materials like step counters that will help the patient to monitor how many steps, monitor how much fat is being burned, and that also brings some income into the pharmacy. Nutrition management is also another source of income. Waste management, when properly done, is another source of income. Your patients might need to go through smoking cessation services, whatever services you render along there. So we are still looking at services within that clinic that can bring income into the pharmacy. Assessment for heart disease risk. We know that diabetes is a risk factor for heart disease. So by the time you take the patient through general assessment, then you're able to also look at comorbidities and help the patient out. You may discover that the BP is high and it has not been addressed. You may discover that your patient's lipid profile is not all right. And then foot care. Foot care is something that is very interesting to do. We do foot care for our patients. We help them to examine their feet, and when there are issues, we refer them. Then sale of monitoring devices, because they need to monitor their sugar regularly. So we encourage them to get glucometers. When we have patients that have to do 360-degree view and they don't have glucometers, we set aside some glucometers that they can borrow, because for that period, they might need to use like half a pack of the test strips for us to monitor what is happening there. So we will allow them to borrow glucometers for that purpose use and come back for those who cannot afford the glucometers. Then test strips, BP meters. And then another income generation from what you do is that they refer other people to you. The moment they are benefiting from you, they are happy and they link other people up with you. So that increases footfall into the pharmacy. Now, let me give you a practical example of one of the novel services that we did at NutriDrugs. We just played around some services and we presented it to the patients. And then we now administer questionnaires to find out if they were willing to pay and how much they would be willing to pay for such services. I didn't mean that we charged them for it. And interestingly, this is what we found out. About 63.2% of them were willing to pay up to 2,000 for that service. Now that service leads to other lifestyle modifications that they will probably have to pay to know. For example, they might need to check their sugar, they might need to check the measuring of blood pressure in most pharmacies are free. They might need to look at their lipid profile and all of that. Then how likely are you to come for this service again? We had 84.2% of them say very likely, and just about 15.8% likely. Nobody was unsure of that. Nobody said not likely. That means that the service added value to them, and they were willing to have that service again and again. And then would you recommend this service to a friend? Everybody that filled the questionnaire said they would. So we also look at, I also brought here graphical representation of glucose, HbA1c, lipid profile tests compared in the last 3 months. Now, I said we had a special program in this month, and that special program has made more people interested in finding out what the HbA1c was within the pharmacy, lipid profile, point of care tests. So we had an upsurge of it. Now let's look at challenges that we have in remuneration for clinical services. Poor perception of clinical pharmacy services can be a challenge. Now, the reason we look at these challenges is not because we want to dwell on the challenges, but we'll find out how we'll surmount these challenges. Like I said earlier, this pay out of pocket syndrome is a big issue. And if many people, their constraint is that they have to bring money out of their pockets. It's not necessarily that they don't want that service. Then a country policy on clinical pharmacy services is also a challenge because it has to change to expand what we can do or what we do as clinical pharmacists, especially now that there is a lot of JAPA of medical doctors and co. I recall 2015 when I was in the UK for fellowship award. One of the things they told us then was that because they had shortage of GPs, they trained pharmacists to be prescriber pharmacists. They went through 6 months course and then they were able to become, they were certified as prescribers to fill the gap. Unhealthy rivalry among healthcare practitioners, we'll look at how to surmount that. Then clinical pharmacist attitude too could be a challenge. Poor layout of some community pharmacies or hospital pharmacies can also be a challenge. There are some layouts that just put off the patient. Some time ago, I referred, a patient wanted a particular drug we didn't have, and I was like, go to pharmacy, so, and this patient said, have you been there before? And I had not been there before at that time. And the patient said, look, they sell anything, close, everything. So sometimes the layouts might be off-putting. Then lack of counseling space is also a challenge. Sometimes there's no space for counseling. Maybe the pharmacy is so small. Let's see how we can surmount these challenges. We need to improve public perception of clinical pharmacy services. How do we do that? We can do researches, we can document our interventions and what our interventions have done. For example, in July, we carried out free screening on hepatitis, and we're able to screen a large number of people. And out of the about 377 people we screened, 100 of them signed up for complete doses of the vaccination. And that is a lot, because that means that if all the 100 people developed immunity to hepatitis B, it means that we have saved 100 people from getting infected. If we put the cost to that, we know how much that means we have saved the country and the community, the country as a whole. So we need to pool resources together. We need to come together, gather all this data and make publications and let the world know what we are doing as clinical pharmacists. When they know, then the public perception will change for the better. Now we have the National Insurance Act to improve health insurance coverage. We must position ourselves in there. We must be able to be recognized to play key roles in that place, because we know that we are usually the first point of call and we are very accessible to our patients. Country policies to promote we should have advocacies to make country policies to promote uptake of clinical pharmacy services based on public needs, expectations, and satisfaction. And of course, it's also through research. We can research to find out what the public needs. That little one we did showed that the public or all the people that participated needed that service. If they didn't need it, they wouldn't say that they were ready to have it again and again or refer other people for that service. In fact, somebody told me and said, look, I wish everybody could just experience what I've just experienced today. So clinical pharmacists should brace up to provide clinical pharmacy services, however little. If you don't have a space for counseling in your pharmacy, you can do home visits. You can do online. No matter how little, there are services that you can render. There's a need to improve pharmacy layouts to promote uptake of clinical pharmacy. We should be able to create a corner, no matter how small, where confidentiality is ensured. So provision of counseling space in community pharmacies or hospitals is another thing that we should be able to do. Now, my take-home points. Clinical pharmacy services are current trends in pharmacy practice globally. To render effective clinical pharmacy services, there's a need for continuous learning and commitment. Remuneration for clinical pharmacy services is achievable despite the not so conducive practice environment. People will pay for needs that are met, be commiserate at the beginning. But on the long run, it will pay off. There's always an opportunity for the clinical pharmacist to render one clinical service or the other. Don't say that you are constrained. Even if you're in the hospital, you can just have online platform to follow up on your patients, encourage your patients, and help them to improve outcome. Like I said earlier, we only looked at one service that we can provide in the pharmacy. There are myriads of them. We've not talked about pharmaceutical care services. We've not talked about medication therapy management. We have not talked about vaccination services as key services. So I also brought out these quotes because I think they are relevant. It says successful people are not gifted. They just work hard, then succeed on purpose. It has to be intentional. We have to decide. And like I said, it's about the patient. The focus is on the patient. When the patient comes in, what goes on in my mind? How do I help this patient patient? How do I solve this patient's problem? How do I help my patient optimize drug therapy? And when we do that, a lot of interventions get made. This other quote says, I've learned that success is to be measured not so much by the position that one has reached in life, as by the obstacles which he has had to overcome while trying to succeed. Don't give up. The beginning is always the hardest. Life rewards those who work hard at it. I started by saying that it's a big topic and we need to discuss. So I've made the presentation as short as possible so that we'll have time for discussion. I'll permit me to conclude by saying that clinical pharmacy service should be a win-win service because it promotes the health of the patients, it bridges interprofessional gaps, and generates income for the pharmacist. The goal is to ensure that the patients, other healthcare professionals, and the pharmacist all have reasons to smile at the end of the day. Thank you, and God bless you all. My references. Let me stop sharing. Was I heard? I hope I wasn't just talking to myself.
No, you're not. We're here. Okay, you can raise up your hand if you have any question. Yeah. Thank you so much for the wonderful presentation. You just gave us a fish eye view. In fact, what you did was just to teach us how to fish so that all of us will bring out our fishing nets and our style of fishing. We'll all learn together. But before I take the next, the hand up, there is something you mentioned that I just want to reiterate. That's a simple willingness to pay analysis was very helpful to you, and that'll be helpful for all of us. And we also live in our comfort zone will help us because sometimes you are used to doing one thing for a long time. You sit down in the office, you can buy and sell and make money, so you don't worry about services. And these are some of the challenges. And then you mentioned health insurance. Yeah, I retired as an MD of HMO for more than 20 years, and this area is particularly touchy to me because there's so much money that goes in millions and billions that is being shared within other health professionals without the pharmacists having a take. This is beyond you or us, but it's what I feel the CPAN will take up because once the NHIS knows that clinical pharmacists can do A, B, or C, then they have their remuneration, and you will be surprised how you turn how you're going to turn everything around. Lastly, there's something you mentioned, and I want to recapture it as ear training. Our people need to learn how to train their ear. That's the term used in music. Train your ear enough to get your patient right so that you won't miss it. Because once you take, a patient is in your hand, you are taking full responsibility. And as you mentioned, documentation helps us. Okay, before I ask my own personal question and make my contribution, I want to give chance to people who are already raising their hands. Is there anybody whose hand is up? If your hand is up, please just unmute yourself and ask your question so that, or make your contribution, as I noted earlier in the text, that all of us should try to make a contribution very, very brief and make it clearer so that others can also participate accordingly. All right. I can't see any hand up here. Okay, President, are you with me, ma? Hello. All right. Is the presenter still there?
Yes, I'm here. Oh.
Okay. While we're waiting for hand up, is it possible you let us? Can you help us? Can you just tell us how to bill? How do you bill a patient for service in clinical setting, pharmacy setting?
Okay.
From your experience.
Like I said, okay. What we have found now is that generally the community, they expect that every service in the pharmacy is free. That is the expectation, because they are used to they are just selling products to us. So that is why I gave that example. So let's look at how remuneration can come in. So we started by, okay, register, because we need to have your documents. We need to be able to help you more. So the register, you put a fee to the registration. And we started with very little and gradually increase it. So you have to start with very little so that they find the value. And when they have registered, then you bring in different kinds of services that can help them. So sometimes they need, like I pointed out there, sometimes they need ancillary products. And by the time they're even refilling their prescriptions from you, that's already something. And then they do point of care. We do a lot of point of care tests. So a patient has certain complaints and you say, look, when last did you check your sugar? Let's assess your risk for this thing. If your risk is high and it's something that you can do within the pharmacy, then you do before you refer the patients. So there are so many other ways, but if as a body, we come to say, these are services that we are rendering, like medication therapy management services, and there's a fee attached to it, then it will apply to everybody, like it is done in the US. They are paid for medication therapy management services. In the UK, they call it medicines optimization. They are paid for it as well. But it's the health insurance that pays, because it saves the government a lot of money. And when I was in the UK, one thing they said was that they proved to the government how much it will save them. And they saw that it was going to save, it's a money-saving venture. So it was not difficult to persuade them to pay them for that service. So we have to be rendering these services before we can say we are attaching remuneration to the services directly. But indirectly, the services can generate funds.
Wow. Okay, let's take a colleague hand is up. Can you unmute yourself and ask your question or make your contribution?
Okay. Good evening, the presenter. It's a very wonderful job. I think it's novel around here. We are not very used to this kind of services. For my question, still borders on placing a cost on these services. If you look carefully, the private hospitals too, they have issues with placing cost on services. That is why most of them cannot do without a hospital pharmacy, because in our climate here, when you render services, we don't seem to value services. So we try to build it into products that are sold along with given along with the services. So in our case here, is it proper to bill our costs of services into the products? For example, I clerk a patient, I solve a problem, then when giving the products, the ancillary products, then I now incorporate the cost into that product. My fear is that if we continue to do that, then the services won't be seen as worth to be worth anything. So I think, so my problem here is, how do we really place a cost on these services and make people to be aware that, yes, these services, this is how much they are worth, and this is what I am charging you for? Thank you.
Well, I'm not very sure that I got that question well, but let me try and explain what I understand. Now, if you were part of this presentation from the very beginning.
Sorry, he was still talking about how do you be the patient? Is he going to be on top of the drugs or what? And if you continue that way, there may be issues, because perhaps the patient may go somewhere else and they'll say, okay, you gave me Augmentin for whatever you did, and Augmentin is say 4,000 naira and you're telling me to pay 10,000 naira. I think that's where she's going. He's talking about what do you do about the billing, effective billing. I think that's still the same question she's asking.
Okay. Well, by our markup, ideally, you should take care of the basics. That's why we have a markup. That's why we're selling at a markup. But you cannot put the cost of your service on your product. I don't think I will advise that. Now we can, like I said, you build particular services targeted at certain conditions. Those are the services that you can get remunerated for. But if you start with remuneration, you may not get far. From our own experience, what we have done, we focus on the patient. We want to help this patient as much as possible. When the patient gets benefit from it, then you can look for areas where remunerations can come. And that's why one of the things I said is that there has to be a lot of critical thinking. There has to be a lot of creativity in what we do. For example, now this patient comes in and all he was is hypertensive, and you are managing, part of his managing for hypertension. You can make him, sell because he needs it. He needs to monitor his pressure on a daily basis or a regular basis. So he needs a BP meter. When he gets that from you, there's some money that has come to you through that. Some other needs, and then you follow up on him, you are monitoring him, he keeps refilling from you, you are getting remunerated. He refers people to you, you are getting remunerated. So you may not have a direct cost except for certain services. And another thing you can do is on special days, you have organized programs that people can come in for. And there's something that is attached to it. Let me give an example of
okay, ma, please let's have more questions so that you can answer more. Because of time is really going. Sorry to cut you off. You can always answer. You can always use this to explain the rest. Our chairman wants to make a statement. Dr. Joseph, man, can we have you?
All right. Good evening, everyone.
Yeah.
Please,
good evening, sir.
Yes, I'm here. Can you hear me well? Good evening.
Sir. Yes.
Okay. Let me first of all thank Pharmacist Mrs. Lawal for coming on the platform of SIPAN. And as someone said, for teaching us a new way to practice. Actually, I believe that most of us learned something new, and we are not used to this form of practice. Yes, it's not usual, but that is the best way, or that is the trend that the world is going towards. We all know that clinical pharmacy is the latest department in the pharmacy profession, and it's still evolving. But what Mrs. Lawal is teaching us this night is actually the way it is being done. So first of all, let me thank her for all the knowledge impartation she has made on us this night, and what we have gained. At least I've learned about follow-up. We should keep on following up, and we should improve on clinical pharmacy or clinical pharmacist perception of the public. If we are doing what Mrs. Lawal is telling us this night, of course, that will change the perception, because many people, even when you say you are a clinical pharmacist, they may not understand, and they think that you are a pharmacist that works in the clinic. So they don't even know that a clinical pharmacist is another type of pharmacist that is specially trained and to focus on direct patient care, patient-centered care. But coming to my contribution, Mr. Moderator, I know you cut Mrs. Lawal off, but then I would have loved her to finish speaking. But since you've given me the opportunity, because I'm not really going to ask a question, rather, I want to make a contribution. And that contribution is that I want to encourage colleagues never to be afraid of billing patients. You don't be afraid. And the fact that you keep on adding your services, the cost of your services to the cost of drugs, means that you're not practicing clinical pharmacy. You are just practicing product-oriented pharmacy. You should not be afraid of costing for your billing for your services. But first of all, as our presenter has taught us this night, you must develop your services. Let me give an example, which I have usually sometimes said on our lectures or clinical meetings. In my pharmacy, for instance, if you come to see me in my pharmacy or any pharmacist there, the first thing that must be done the moment you said is for medical reasons, you want to see the pharmacist, your vital signs must be taken. That vital signs include your BP, your weight, your height, you know, all those things. Then it must be taken. That is the way we practice. And then you pay consultation fee. We are not hiding it. For now, we charge 1,000 naira consultation fee. It's not much. That does not mean that if we render other services, we are not going to bill you for that. But just to see the pharmacist, you must pay 1,000 naira. And I'm telling you that many people are happy to pay that because they know that there is something they are getting. There are a lot of people that didn't come to talk about their BP. They are not complaining about high blood pressure. But by the time you check the BP, you may be getting 170, above 170. And you repeat it, it is still at that level. So at that time, you need to cancel the patient. If they're already on drugs, you know what to do. If you are to refer, you know what to refer. So you see, sometimes you even check some person's BP and it's very, your patients or your clients. And then Pharmacist Lawa also talked that they do a lot of point of care tests. So, and we all know if you learn the skills, we know the skills of these tests, they will also be giving us extra income. So we all believe, and that is why TIFA decided to do this meeting. Sorry, am I still audible? Sorry, I'm rounding up. Am I still audible? Hello? Yes. I said that is why I decided in Japan that we have, it's not all about knowledge impartation, but we also need food on our table. So how do we make small things? And thank God we brought somebody like Pharmacist Lawal. I want to thank her so much for this. Thank God she's already a member of Sipan Pool of Experts. Assuming she's not part of Sipan Pool of Experts, we did that. But thank God she's one of us and she's already helping us in many things. I believe by the time we also invite her on another situation, cases like this, she will still come and update us. That is what I have to say at this point. Sorry for speaking for too long. God bless us all.
Okay, thank you very much, sir. Can we take Abrazak Ayuba? Your hand is up. Can we have? Are you ready for us now?
Yes, thank you very much. I want to appreciate.
Please, can we address you properly? Are you doctor or farm?
I'm doctor. Pharmacist
okay,
doctor.
Dr. Ayuba, thank you, sir. Thank you, sir. Go ahead, sir.
Yes, thank you. I want to appreciate Pharmacist, my speaker, for giving us the elaborate area of generating more income as a clinical pharmacist. But I want to add here that most of the challenges he mentions is quite happening in our practice as a community pharmacist. But I want to beg here that now we have new law. New bill has been approved or by the President of Federal Republic of Nigeria for the practice of pharmacists. But I want to beg all of us as a pharmacist and also beg the Association of Community Pharmacists for bringing out a clinical guideline for practice of pharmacists in Nigeria. When you go to some pharmacy, you definitely know that even the stocking level is not encouraging. And the practice, the people you meet there, they cannot give you any clinical practice. We have a lot of we have quite a number of intern pharmacists. We have our colleagues. When you practice a clinical pharmacist, you must be able to see all these points of care so that you can generate more money and then bring out, clinical paradigm shift, the current trends in the practice of pharmacy. But you'll find out that some of us we don't mind most of what we have learned and put them into practice, what we've learned, what we've acquired through the university, through PharmD, through WAPCP, through all these workshops and all the rest. So by the time we change our attitude, then the community pharmacists will embrace the new law. You will see that all of us, our practice will change. You don't need to write that you're a clinical pharmacist. The number of services you put on board in your pharmacy will automatically bring more returns of your practice. You bring more returns, bring more money. When somebody comes, you can imagine somebody come to your shop and you have you need to take medication and you are giving him pure water. By the time you bring in bottled water and then maybe has not eaten, you have juice, and this will also bring more money, food and drug. These are some of the things we need to bring on board. Then the reception, most of these things are very just area of communications. But when you go to some people, we don't have. When you don't have a drug, you're able to give a very good drug that can give you another alternative. And these are the area I want to encourage our colleagues. We need to bring more, paradigm shift, new modern, new approaches so that we can get more money.
Round up, sir?
Yes.
Thank you.
Today, you find out that we have competitors. This is another area I want to see. Most of the patent medicine, unregistered patent medicine vendors in our community, they sell fake drugs. Most of these fake drugs are very cheap. And you can now see that they are, a threat to I look at my street where I am. You find out that the number of patent medicine stores offer, shadow the number of pharmacies. So, and they also claim that they know more than pharmacists. And these are some of the challenges. And that's the new law. We need to work together. We need to come together. Either you are in academic, you are in the hospital, you are in community. Let us work together to make sure that we bring new paradigm shift to the benefit of the populace. Thank you very much.
Thank you. Moderator, should I take more questions or do you want to respond so far?
So I think we can take more because of time.
I have that cookie here. Please address introduce yourself formally and then make your question simple or your contribution. Thank you.
All right. Good evening, professional colleagues. I must commend the effort of Dr. Olashade Lawal for such an interesting presentation. It was quite educative, and I must say I've learned a lot from this. And as far as this topic is concerned, to the best of my understanding, I think clinical pharmacists in the community setting stand a chance to benefit immensely from this. From the clinics you made mention of, clinics in the pharmacies and so on. And then my question is this: how do clinical pharmacists practicing the hospital setting key into this, most especially those with vast knowledge on some of those, chronic illnesses, such as maybe liver disease, liver diseases and maybe cardiovascular diseases. So they could impact more and then maybe earn more income. Thank you so much.
Okay, moderator, please have the question. Let Ngozi Josephine Able just give us a question and you take the rest, take it from there. Ngozi, we're ready for you.
Hello, good evening, everybody. My name is Pharmacist Ngozi Able. I'm in the community pharmacy practice. I'm glad to be here, and I'm sorry I came in late, but I was able to get the last part of Pharmacist Falashade's lecture. She has always hit everything on the head each time she comes out to give us lectures. She's always excelled. Now, I just want to comment on some of our colleagues, especially the young pharmacists. Like in my own practice, I always have either a copper or internee helping out when I'm not there. And from all that we have been taught, I expect that the young pharmacists should be able to key in, because they are being taught the new the latest techniques in teaching and all that. Not like some of us who have had to go in through consultancy and all that. So you ask a young pharmacist to clock a patient. I don't know why they have a challenge in clocking their patients. They're always in a hurry to stand in front. Somebody says, I want to see a pharmacist, and they just stand there and begin to, okay, I'll give you this, I'll give you that. You start prescribing immediately, there's no documentation. And I always have it, I find it a challenge, because in my own practice, I always, if I need to see a pharmacist, a patient or a client, I have a book for each of those my clients, and I insist that anyone that comes in, or any of my clients that come in, even if I'm not around, you open each of the patient's folder, and then you document what you are expected to do in the patients. You clock the patient so that when I'm not around, I'm able to follow up on what the patient is on. And they find it difficult. Most times they keep asking me that why do I open a folder for a patient, that they find it difficult. They find asking them to pay an extra, to pay money for those, for opening folders for them. So this evening when Dr. Madu was talking about how he was able to, that you charge, when you want to see a patient, you want to see a pharmacist, you should be able to say, there should be a price for you to see the pharmacist. And as he said, all those parameters, temperature reading, weight, and all those are also costs that should be imbibed into the patient's bill. So my young pharmacists find it difficult to actually apply this kind of billing method. They believe that it makes the patient not want to see the pharmacist. But I keep telling them, I've been in this practice for years, and if you are able to get that kind of standard, and we have for over 10 years, we have patients' folders that have been in my community pharmacy for years. But as you grow older, you are no longer as permanent as you are supposed to be in the pharmacy. So you get younger ones to, so how do you get these younger ones to make sure that they actually practice as a pharmacist? Because with that way, you are able to increase your remuneration, and the patient feels that actually that what he can get from a hospital, he can easily get it, at least as a first-hand information from you, who is the consultant and who is the pharmacist, and before you can now refer. So I am so happy this evening because of the information we are getting, especially from Dr. Madu, from Pharmacist Falashade. Falashade, good evening. And thank you so much for your wonderful presentation. Thank you very much.
Okay, thank you so much. All right, we are running out of time, and I will really appreciate if further contribution will be how you have applied this principle, and what others can learn from your own practice. Presenter, can you help us answer the question on how do you apply this in the hospital setting?
Okay. You know, now we are having different specialties by clinical pharmacists, and I think that is the way to go. We're having nephrology pharmacy, oncology pharmacies. Those are specialty services that are being rendered. So now I don't think that you can put a fee to those services directly by yourself because you're under employment. So it's an employer that can determine your worth, but you can't make your employer value you through what you bring on the table. And it should go beyond mere action. There should be proper documentations. You should be able to translate your intervention into the cost that you are saving the establishment. Then you can make a case to say, we are doing this and that, and through this intervention, we're saving the establishment so amount of money, and then you can press for salary increase. I think that is what can happen with government hospitals, because government determines how much to pay you. You cannot go and charge the patient, but you can make yourself more. Like I said, for me, the most important thing is what do you have to bring to the table? Your focus is improving the patient's care. And like, sorry, I draw a lot of inspirations from the Bible. Seek first the kingdom, what them other things will follow. So as you focus on, I always say that Pharmacist ministry is a call to save life. As you focus on that, the denomination will naturally follow. That is my own experience in the 30 years that I've practiced.
Wow. Thank you so much. Okay, let me just add my own experience in my practice. Perhaps others can learn something from that. I haven't been in the health insurance industry for a long time. That's something I applied in my clinical setting. First of all, I have a side lab with a lab scientist, and I'll have a referral system, organized referral system that I practice. And as a matter of fact, I do what I call global billing, and it worked for me. When a patient comes, go to the vital signs, go to the lab system, and I'll tell you, for this is how much you're going to pay. Sometimes they bargain, sometimes they don't. That way, I have the patient by my hands. A few years ago, I had somebody that trained us on something. He said, don't ever bill out of hunger. You don't just bill out of hunger because you are looking for 10,000 naira somewhere else. Something if you bill for 50,000 naira, I want to bill it for 15,000 naira. Our problem is that we need to develop depth, confidence, and confidence comes out of knowledge. Clinical judgment is not free anywhere in the world. It's not free. And I can tell you the truth. I have used a drug of 5,000 naira to treat a patient for 60,000 and the person paid and say, thank you very much. And that's what I normally tell my staff. If a patient can go through you, pay and say thank you, then you have done it well. Then we can do the follow-up system. I used to do this 2,000 naira before for consultation. I found out that it does not pay me as much as this particular one. Now, this is my own personal experience. Others can learn. Chinyere Okonkwo, are you there? Can you just give your question before the presenter rounds up?
Okay, I'm here. Good evening, all. Thank you
evening,
so much, ma. Your presentation was wonderful, ma. Okay, I just wanted to add to what the last person that asked the question said. She said, how do she bring in the younger ones? Like you said, you the moderator, it's a process. Build your process. When you build your process in your business, any other person coming into your business will follow suit. You have someone who is in recruitment, you have someone who is in clinicals, you have someone, this is our process. They already know that when you come, they take vital signs before you go there. Once any other new person comes in, even if the person, your major person goes, and once any other person comes in, they follow that process. That is one thing I have learned in pharmacy business. You build your process. And that is why your business can even run when you're not there. Your business cannot shut down because there is a process in place. And that process is what checkmates everything that happens. If they didn't document, you will find out. If they're documented, you will find out. If there is shortage of anything, you will find out. You understand? And that place I wanted to contribute again is the NHI Act. I was opportuned to be there in the debriefing in Abuja sometime last 2 months while they were briefing and, trying to break down the act so that everybody will understand. It's now an act. So, and they are now like a liability company kind of. So they can be sued and they can sue you, But among all these, along the line, I found out that there was no place that pharmacy, even community pharmacy, was captured as a primary healthcare provider. I tried to ask the DG the question. It was like that he would visit that they are still in process. Really, they are still in process. And there are so many lacunas in NHI Act. Like the other day in our hospital, they were having issues. They were having issues with prescription. Okay, they said, why should a doctor a patient walked in and complained of headache and this and that, and you're prescribing like 3 NSAIDs. He wasn't even conservative in his prescription. And they were complaining that this is something that even the community pharmacy can do for them. And if it will save them costs. Obviously, the community pharmacy won't give them up to 3 NSAIDs and that. It's a place you can cash in. Instead of all those minor things, teaching hospitals, actually referral hospitals. You understand? GOPDs are there as their primary healthcare provider. So we can even still cash in because the GOPD is not capturing all of them and we will still do the referral. If we can write this proposal to NHIA, I am telling you that pharmacy will just land themselves in limelight. Because that is what they have been looking for, how to cut costs at all, how to reduce their overhead at all costs. You understand? We'll tell them if we come in as this, we step in as this, we do the basic diagnosis. Their triaging is just the triaging in teaching hospitals is just this, big kind of, they just land you with heavy, someone who is just coming to GOPD, you're giving the person Meronem. Why are you giving the person Meronem? Have you tried other empirical antibiotics? No. These are areas where we can cash in, and I'm telling you, pharmacy will be something else. Thank you.
Thank you so much. But let me just say something about the NHIS, since that's my specialty. The truth is that pharmacy, according to NHIS, is seen as a secondary care provider. That's where the problem is. And for you to be a primary care provider, there's a setting that is required by the NHIS. That is the truth. There should be a ward, that should be GOPD and stuffs like that. And this is where the issue of pharmacy clinic comes. If we are going to do anything about this, because our colleague earlier on couldn't do much. They couldn't do much at all. They couldn't mount pressure in anything. Even the secondary care provider issue, they couldn't even get anything because The hospital we are told to pay the pharmacies, and the pharmacies refuse everything. So your money for drugs still go back to the hospital. So the pharmacy is put out of NHIS. And I can tell you this is a multi-billion business. Yeah, I remember my first 3 years as MD of a HMO. I was driving fairly used car until the NHIS paid. Our company paid bought as much as 50 brand new cars at the same time. The money that's going there, it's like free money. That's the truth. I believe that if CPAN is going to come down together, liaise with NHIS, know what they actually want for CPAN. CPAN can match that. Then we can take it from there. But as it is now, I can tell you, the NHIS can never take pharmacies as primary care. No, they won't do that. That's the truth. Okay, moderate. The presenter, thank you so much for your time. This is one of the most important things we've ever learned. And I want to thank you for letting us know that we need to put food on our table. And that's just the truth. On this note, I want to say, I want you to round up so that if there's any further question we may take, I can round up for the day. Thank you. All right. In absence of any other question, I don't know whether Dr. Mad, are you still there? Dr. Motihad, are you still there?
Yes, I'm here.
Okay, that's fine. Is Dr. Motihad there? Okay, she has gone home. Okay, can you give us some remarks, Chairman, sir, before the moderator rounds up?
Okay, once more, I think, hello, can you hear me?
We can hear you, sir.
Hello. All right.
Go ahead, sir.
There is nothing much again I can say. Yes, I know I tried to put it into what I was saying initially. And as you have said, as the moderator, we need to put food on our table. It's not all about clinical knowledge, and maybe a clinical pharmacist. By the time you see him tomorrow, he has nothing to show for it. And like what I think somebody, the last speaker, the one lady, is it Chinenyo or somebody? She was talking about the NHIA, that's NHI Act, and other things, and it has just been said that pharmacy is not there. Then you, the moderator, has said that pharmacy is on the secondary care provider. Chinenye was talking about how we can come in. Of course, we are discussing, and probably we still go back to PSN and SCPN and talk to them and see how we can work together. When we get knowledge like this, like what we are gathering from this meeting, I'm already making notes. And I believe that wherever I find myself, we'll put in there. Thank God we have a new law, and that law defines community pharmacy as a healthcare facility. Let me put it that way. Before now, some people do not even define what a community pharmacy is. But now the law itself has defined it as a healthcare facility. So, and the pharmacist itself is a healthcare provider. I think that has solved some problems. The law is also talking about pharmaceutical care. The law also defined pharmaceutical care. The law defined clinical interventions and collaborative drug therapy management and the rest of them. So I think the law is at least a bit updated. And after now, people won't say, why are we touching patients? The law has given us the strength. By the time PCN also comes up, because I know there are plans to also change what is on the pharmacist license. I believe pharmaceutical care will be there, and it will strengthen us a little, at least legally, and we can now showcase what we can do as pharmacists or clinical pharmacists. These things will really help this profession. So I want to thank Dr. Folashade Lawal once more for what he has done. I know that if we are to pay, we cannot pay. In fact, when I was listening to this lecture, I felt as if I was sent outside Nigeria to go and study how to practice pharmacy, community pharmacy. I wasn't feeling as if I'm learning this in Nigeria, but this is a Nigerian practicing and doing all this. So we thank you very much, ma, for what you have done for us this night. The good Lord will reward you a million folds. We cannot pay. If we are to pay honorarium, I know how much it will run into. On this note, I want to say thank you to everyone, every participant, because without participants, there will be no meeting. May God reward all of us, and let us continue this way, because this is the only way to go. In a few years' time, even right now with what we are doing, and people, the nomenclature clinical pharmacists is almost becoming a household name in Nigeria. So please let us all continue. No other person will make this profession better for us except all of us. We don't expect physicians or nurses to do it, but we pharmacists must do it. And we can even overtake other people. So thank you very much. God bless us all.
Thank you, Mr. Chairman. Thank you for capturing everything again. I don't know whether any of the co-hosts is available to make a remark. Dr. Ibrahim, Dr. Motihat, Dr. Abdulmuni. Any of you, can you just give us some remark before we round up? Unmute yourself and go ahead. Dr. Bella, are you there? Are you still there? Or have you gone home?
Yeah. Hold on, Dr. Onedu. What I want you to add is that the recording of this is live on YouTube. People can go back later and review it.
Okay, that's fine.
It's live. I can go back and review. It's a good one, loaded with information. Thank you.
Thank you. Thank you for doing a great job. God bless you and keep you. All right. Can we take the proposing prayers? Anybody want to say anything? Ibrahim Abbas, are you there? Ibrahim Abbas, if you are there, can you just give us a closing prayer and a remark? Okay.
Good evening, everyone.
Okay, go ahead.
I don't know, is it Regina James or Dr. Regina James?
Go ahead.
Hello.
Dr. Regina, go ahead.
We can hear you. Okay. Thank you very much for this opportunity. I want to
give us a comment and then give us a closing prayer.
Okay, I just want to join my voice to appreciate our presenter, our very able presenter. We thank you for enlightening us, for actually showing us how to increase our income by our practice. Well, that is what we have studied, and that should place food on our table. That should put roof over our heads. Thank you so very much for showing us all of this. And I want to appreciate all those that came out for this meeting. This meeting today, we recorded 100 participants. And I want to encourage us to keep coming every Friday. We have presentations like this that actually build us up and help us to practice this profession in a way that, as she has said, I will put food on our table. So I encourage everyone next Friday, every Friday, come out so that we will learn more. We mentioned that as a clinical pharmacist, we have to be lifelong learners. So let us keep coming and learn. As we learn, the practice comes out of us naturally. Like I said, we have to look at all other professionals in the country. They are all improving. Some are even trying to go ahead of us. Some years back, it used to be pharmacists. Please let us continue with the tempo and take our profession to higher level. That is what I have to say. Now,
Okay, who was the closing prayer, please? Who was the closing prayer?
okay, can we take the closing prayer, please?
Go ahead.
Okay, I hope I'm audible. Almighty God, we appreciate you. We thank you for the presentation tonight. We thank you for what you are doing with pharmacy profession in Nigeria. Thank you for CPAN that is actually giving us the platform to stand and practice this profession. We are asking, Lord, that you take us higher and higher. And as we all go back to sleep tonight, Lord, we are asking that you help us. Lord, I'm also using this time to pray concerning our country, to pray concerning the flood that is taking some parts of the country. Our colleagues are part of them. In some of these parts of the country, our colleagues are involved. Lord God, we are asking for a solution to this problem, that our colleagues will not, because of our colleagues that are among them, that there shall be a problem, there shall be a solution to this flood problem. In Jesus' name. Amen. Amen.
Amen.
Amen.
Amen. Amen. Thank you and God bless you. Good night, everyone.